Okay, welcome back to the final session. We've got 3 talks to finish off today's symposium. It gives me great pleasure to introduce Sonia Lockwood, who's a surgeon down the road at Bradford, a small town near Leeds. Sonia, I've got a lot of respect for her as a surgeon, but she's clearly gone over to the dark side to practice the dark arts of being a manager. Sonia.
Thank you, Pete. Thank you, Jill, and thank you to the ASGBI for having me speak this afternoon. Next slide, please. So there was a good study and a survey put out by the Nuffield Trust in 2002, repeated again in 2017, which aimed to look at the difference between clinicians and managers and what doctors' perceptions of managers were. And that study showed that there was a huge gulf between clinicians and managers in what they in agreement on clinical issues and organisational issues. Managers and senior doctors were seen to disagree on the level of influence and involvement that doctors should have within the hospital management structure, the balance between financial and clinical priorities, and also the quality of both clinical and managerial staff. Interestingly, this data was followed up by another paper published in 2013 in the BMJ, where chief executives were asked about the quality of their medical staff, which was universally reported as high, whereas clinical staff generally don't have very much regard for the managers. The Swedish study back in 2010 also confirmed a gulf between clinicians and management, and that doctors have ultimately believe that they have a limited capability to influence change within their organisation, and as such, there was disengagement of clinicians from management. The Francis report back in 2013 had highlighted this again and showed that clinicians should be encouraged and there should be greater clinical engagement in management in order to improve outcomes. Next slide, please. So, contrary to Pete, I am a reluctant manager, shall I say, and you'll see that throughout the slides I've converted manager and leadership and swapped those two terms into interchangeably throughout the talk. But I'm a reluctant manager because actually I enjoy surgery. I'm a clinician, I enjoy operating, I enjoy my clinical role. I've never sought a managerial role. It's not something I'm remotely interested in. I've had no management training, and having been a consultant for 6.5 years at Bradford Teaching Hospitals, I think it's fair to say that I've got no idea about how to balance the clinical and organisational priorities within our trust. I have no idea about the complexities of the local regional healthcare agenda in our area. I certainly have no input or felt I had no influence in how to allocate resources, and I had no interest in being involved in hospital managerial politics. Next slide, please. But at the beginning of March, my anaesthetist is one of our deputy medical directors, and he said, your hospital needs you. We'd like some help, please. Next slide, please. At the beginning of March, COVID-19 had hit the UK. Our hospital had already got quite a good grasp of the disease. We had 3 or 4 very engaged anaesthetists that had followed the COVID crisis in China and in Europe at the start of the year. And it became quite easy being a manager because there was a single common goal, and that was to stop all activity across the trust. Next slide, please. Not quite so long after that, about 6 or 8 weeks, it became evident that actually the major project that was going to be undertaken is how to restart activity. And there was a wealth of guidelines, guidance, papers, documents that came from a series of stakeholders from the World Health Organization downwards. And taking each part of these bits of guidance and guidelines and bringing them together was one of the biggest challenges. Next slide, please. So I'll take you through a roadmap of our plan to restart and the things that we had to take into account and give an indication really of the issues that were involved. By far, the first thing that we were concerned about was infection prevention and control measures, how we were going to get PPE, who had to wear PPE, where PPE was going to be, and what that meant. In Bradford, particularly, the nursing staff were a huge issue. We had a lot of sickness at the early days. About our height, we had 60% of our nursing staff off now down to much less than 5%. But not only were nursing staff off sick, but there were nursing staff that were redeployed throughout the trust. Slightly less in the way of sickness for medical staff, but medical staff were also redeployed and trying to get them back to where they're working. The junior doctors, particularly across the medical rotas, was difficult. We knew that we had the priority of cancer, and cancer care has continued in Bradford throughout the pandemic and onwards. But our main issue is that access to diagnostics, particularly endoscopy and colonoscopy, with the concerns about aerosol generation. We also had to stop due to some of our hospital estate and what availability we had for diagnostics for the acute take as well as the electives in trying to get those services back up and running. We won't be in isolation if you think about the waiting lists that were generated over the 3 or 4 months where we weren't actually doing any real work. For those of you who don't know Bradford Hospital, it's a large old Victorian building. It's hundreds of years old. It's probably not fit for a purpose before the pandemic, but it's become quite evident that the hospital estate in Bradford is nowhere near acceptable. We're probably one of the only hospitals in the country that still run on Nightingale wards. 5 or 6 of them have closed because Infection Prevention and Control have realised that we can't put COVID or potential COVID patients on there, let alone that these were our colorectal wards. But the hospital estate has become a huge issue. We were quite crippled by the fact that we don't have a separate day case unit. We only have one site with our second site just been servicing the outpatients, and trying to restart a hospital with half of the estate that's now no longer fit for purpose has been extremely difficult. As part of the leadership team, we've been involved in risk assessment. What is the risk of COVID? What is the risk of not doing work? What is the risk of postponing work? What is the risk of returning it back to the GPs? And there's been operational agreement across the trust and across the wider healthcare service about how we provide these, how we restart a service and provide particularly quite a lot of the elective surgical interventions. So you'd think that restart would start, but I've seen our COVID data from today. We're back to 14 inpatients, 3 on non-invasive ventilation, 1 on invasive ventilation, and we're seeing a spike. Bradford has been in the top 5 areas across the country that has had the highest COVID rates. We've never seen a reduction in the community, and I suspect that all this work that we've put into trying to restart elective work may well come to a grinding halt if the figures in the press are to be believed. Next slide, please. So what can I tell you about management? I can tell you that I know how to do a Zoom call, a WebEx meeting, and a Microsoft Teams call. I'm very familiar with the phrase, please go on mute if you're not speaking. I've seen more Excel spreadsheets than I care to remember, and my inbox is always full of emails regarding management meetings and the next invite. Next slide, please. But I've had a little look, actually, and the Royal College of Surgeons is quite clear about whether surgeons can or should be managers, and they've swapped that word from managers to leaders. And one of the reasons that I think that we're able to do it is that the college will state these are the things that make effective leaders. One is that we have a sense of duty to our colleagues, a sense of duty to our juniors and our peers, and a sense of duty to our patients. By the very nature of what we do, we're accountable for what our endeavours, both in surgery and in a managerial setting. We always work on a team-based approach, and if you don't take help from your colleagues, then I'd say that you're foolish, because my colleagues are my best friends and also get me out of trouble for quite a long time, both personally and professionally, making sure that I toe the line, shall we say. We're very good at empowering members of our team, and you can see that in the World Health Organization WHO safety checklist. And if you're thinking about surgery and management, we like to make sure that everybody in the team is able to speak up, is able to have an input into any of the clinical scenarios. We learn from our experience, we learn from our mistakes, and they can be successes and failures. But more importantly, as surgeons, we're adaptable, and you can see through many of the presentations today that we're still keen to change our practice, we're still keen to improve our practice, and I think that's what makes a good manager or leader. Next slide, please. So are doctors, and do doctors make good managers, and do they make good leaders in the hospital? There's an Australian paper that was published in 2017 in the BMJ that clearly shows that doctors want to be led by doctors, but those that do the leading often find it quite difficult to act in a managerial capacity with their colleagues. But we can see from a lot of the data that it's hard to be a leader if you don't actually have the clinical expertise to see how any of those decisions that you make impact on the quality of care. Doctors trust other physicians to make the right decisions about healthcare delivery. And I think it's fair to say that we are all aware that there are costs and financial implications to providing healthcare, but that has to be balanced with clinical priority. And certainly with the COVID era, clinical priority has come to the forefront. So a good working relationship between doctors and management is critical for the health and safety of patients and for the colleagues around them. Doctors leading and doctors being involved in senior management has been shown to positively influence patient outcomes and also the quality of care provided by healthcare services. Next slide, please. I would hope that Bradford are not in isolation in taking this ethos and providing it in the form of a clinical reference group. So at the start of COVID, we have a clinical reference group, Silver, which is made up of about 50 different members of clinical staff, including doctors and physicians, nurses, and professions allied to healthcare. There's no longer a managerial structure with a top-down approach, but indeed a bottom-up approach. And everything that's happened through COVID has happened through the clinical structure rather than through a managerial structure. Next slide, please. Can anyone lead? And I think any surgeon can lead. And those people on the Zoom meeting today will know that we have these qualities, and this is what the Royal College of Surgeons aspire to as a good leader, that we've got integrity, we're aware of our own limitations, we're accessible, we're decisive and can make decisions, but we're able to respond to feedback and change those decisions if needs be, but be consistent in our approach and organised. Next slide, please. Finally, am I a manager? Am I a leader? Well, I take on emergency surgery, a lot of my interest in emergency surgery, and I'd say that being a manager at this particular crisis time in our history it is akin to surgery. If someone asks you for help, when you need an emergency laparotomy, we help. Someone's asked for help, I've helped. I'm familiar with risk assessments, as we all are. We're infinitely more not risk averse, sorry, we're infinitely better at taking risks than some of our other physician-based colleagues. We're familiar with time-critical situations and time-critical decisions, and we're also familiar with the concept of a multidisciplinary team making. We work in surgery on assessment, reassessment, and take feedback from others. And like any surgeon, you won't go into an emergency laparotomy without an exit strategy, and I'm currently working on mine just now. Thank you very much.
Thanks, Sonia, for very sensible and thoughtful comments on the administration, the difficulties that they face. Jill.
And so now I'd like to introduce Giles Bond-Smith, who is an ASGBI regional representative and also an acute surgeon in Oxford. Giles.
Thank you very much, Jill and Pete, and congratulations on a fantastic conference. I'll be speaking today about communication in PPE. Next slide, please. It's a problem I don't think at the beginning of the year really touched people's minds, but I think since COVID has come along, it's become an increasing problem. Next slide, please. The main issue is that PPE is going to become the new normal, and there's all different levels of PPE, all of which can cause difficulties in communication, even with level 1, where you just have a simple face mask across, because if you're reliant on lip reading, that creates a problem. Forgetting that for one side, some of these devices, especially the sort of Force 10, in some of those pictures, you can see people wearing this great big headgear with ventilators behind them and motors whirring away. They're very noisy. And when you're in that space with a mask over the top, it's very difficult not only to hear what's going on, but to be heard as well. And actually, it's surprising how many of medical staff that you work with on a daily basis have some sort of hearing issue. Next slide, please. It's not a new problem, communication in the NHS, in theatre, in actual fact, and we spend a lot of time nowadays trying to improve communication within the theatre environment. There's lots of staff in theatre. It's a closed environment. It can get very, very noisy indeed, just with the hustle and bustle of people being around. It's stressful, and there's lots of evidence that states that the more stressful an environment becomes, then that communication goes, accurate communication, should I say, goes out the window. And the WHO has sort of, in some guys, has sort of attempted to sort of bring this together in a nice, calm manner at the beginning of an operating list, so that everybody understands exactly what's going on, where and when, have we got the right equipment. Next slide, please. So the risks of PPE added into that environment with all the noise, stress, lots of people banging and clattering of instruments, diathermy going on. What does PPE, how does that increase the risk? Well, it's, as we've just been saying, it's very, very difficult to be heard and to hear. We've in our trust have had some untoward incidents where the wrong medication's been brought, the wrong instruments have been got, or in fact, you know, the wrong patient's been sent for just through lack of ability to communicate accurately. I've put a picture up there because that's how many people do that on a daily basis, especially when you're wearing level 1 on the ward round. You're talking to a patient, the patient says, "What did you say?" And you take your mask off and say, "I told you so." You know, it's ridiculous. You're putting yourself at risk and your patient at risk by removing your mask. And that's at level 1. When you start getting up to level 2, etc., even more so. There's been documented evidence where people have actually had to leave theatre in order to communicate properly. I mean, that's not a great situation where you've got people leaving theatre, wasting vital PPE supplies, wasting time, just so that they can communicate clearly. And in actual fact, if you've got a COVID positive patient, coming in and out of theatre is not going to be possible anyway. Next slide, please. So what are the solutions? Well, I'm sure a lot of you have sort of come up with this sort of two-way radio, which allows good communication between inside and outside of theatre. You can hold it. It's what I call NHS proof, because so much equipment just gets dropped on the floor a lot. There's good battery life, because how often are we go for a bit of equipment and it's not charged, or the battery life runs out. The two-way radio, it is pretty cheap and it's robust. The problem with it is you can't use it if you're scrubbed that easily, and trying to speak into a microphone when there's a lot of noise going on is often hard, and especially if you're wearing level 3 PPE, the full-on headgear and everything, very, very difficult to actually hear what's coming out of the microphone sometime. And then what was pointed out to me not too long ago was actual confidentiality. You can hear, you know, everybody in the room can hear exactly what's going on, and you may be in a corridor. So patient confidentiality is not great there. Next slide, please. So being Oxford, what did we do? Well, we went for this sort of artificial intelligence device. Now, I'll tell you, this device is fantastic. It is proper Star Trek Next Generation. That picture there, you wear just on your side. It's controlled exactly like any sort of smartphone. You just say Vocera, call Jill Tierney, and it calls Jill Tierney, and Jill Tierney will hear, Giles Bond-Smith, consultant surgeon from Theatre 4, is calling you. And the functionality is so good. It would totally replace bleeps. It works on internet. So we're 4 hospitals in the trust on split sites, and it works all over the place very, very easily. The thing about it is it's eye-wateringly expensive. And even then, when you're scrubbed, if you try and wear it with a respirator, the Vocera doesn't pick you up. So it was really it was difficult to use scrubbed and with any sort of headgear. So again, didn't really solve the problem of accurate communication, especially between the surgeon, the anaesthetist, and the scrub team. Next slide, please. So So what did we do? Well, we went dark. We went to the military, asked them what they do. Let's face it, they work in pretty stressful environments. They're noisy. There's a big team. What do they do? And all of these people came up with this thing called bone conduction microphones. Now, you may remember the old thing where they wear it around their throats. They tend now, as that picture shows, is to wear these in-ear headphones, but they're actually microphones. It's a phenomenal piece of kit. The engineering behind it is just exceptional. What it allows you to do is you can whisper, something that I'm not particularly good at. But if you just whisper, everybody can hear you so clearly. There's actually external and in-ear versions. And it's cheap. It's cheap as chips to have, because effectively you're just buying a headset which can plug into any sort of radio controlled device. And it allows all members, you can wear it when you're scrubbed, because you just have the earpieces and everybody can hear you talking. Depending on your radio pack, you can voice turn on or off your channels. The one thing I would say is that, having tried it in Oxford, the in-ear pieces, if you're wearing it for a long time, can become uncomfortable. And because it's based on you're using it with a radio, you may need boosters to ensure you've got great coverage across across the area that you want to do. So it may not be theatre, but for us, we wanted to communicate between theatre and resus, ED, ITU. We needed boosters just to try and ensure that we could communicate through those areas. Next slide, please. So we did well, basically, was when COVID hit, in that chaos, we got these in-ear two-way radio mics allowed in for 2 weeks. It was the quickest implementation of a novel device I've ever known. And what we found was that all members of the team could be on the same channel, and it was crystal clear, even with the anaesthetists wearing their Force 10 masks and big respirators on, we could clearly be heard. Everybody was on one channel, but you could have multiple channels, which meant that I could change my channel and actually talk to the theatre and all their staff next door. So if I had a junior there that was starting an operation, then wanted some advice, he could let me know instantly. We did need to get boosters to make this work, as I said, which will obviously have a cost, but by and large, it was a really good model that we found it worked. Next slide, please. I'm just going to say what was really interesting is that it worked until the sort of management came back in, and then they've stopped us from using stopped us from using it until we could prove it worked. But we'd proven it would work, people were using it, but we're having to go through process now at the moment. So I'm not, I can't say that we're actually using it at the moment in Oxford. But you know what? Look, communication is difficult now in theatre with PPE. It needs a robust solution. And I'm just going to throw out there that two-way radio is cheap. If you add in your bone conduction microphones and earpieces, they're cheap, reliable, they're NHS proof, but ultimately we've got to keep working hard. Next slide, please. Thanks very much. Happy to talk more. There's some details if you want to get details of any products up there. Thank you.
That's great. Thanks, Giles. I'm sure we'll be able to come back to some of the questions about that later. Pete?
As for our final presentation with our sponsor, Ethicon, I'd like to ask Amy Peters to address the topic of smoke evacuation in the OR.
Yes, thank you very much. And I'm really honored to have a space here. And I also want to thank Sonia and Giles perhaps for setting me up a little bit, because I think what coronavirus has really shown us is that the world as we know it has changed. And when we stopped elective surgery, we had no idea how difficult it would be to actually restart it. So can you go to the next slide, please? And really, the big challenge, as Sonia had mentioned, is infection prevention and infection control. And we tend to sort of think of the patients on the table rather than the actual surgical staff. But we certainly need to consider actually thinking about our staff and our OR, because surgical smoke is a byproduct of most operations now. We know at 4 and 5 operations, there will be surgical smoke there. And so we think about actually, okay, so what is in surgical smoke? 95% of it is water, no problem. But the other 5% of it is actually organic and inorganic compounds. And we found that in the inorganic compounds, there are actually viruses and bacteria present, like HPV, HIV, amongst others. And what happens in theater is that the particles per cubic feet can go anywhere from sort of 60,000 to over 1 million in a very small space. So we really do have to consider, now that we're thinking about restarting surgery and the impact of coronavirus on surgery and on theaters, actually thinking about our staff as well. Now, the challenge that I see is that no one is actually, it's nothing new. So smoke is a critical issue. Surgical smoke is a critical issue. But we aren't really talking about it much anymore. I think the topic has been around for a while. There is certainly current legislation in place. MHRA has made some recommendations, but they aren't oftentimes actually followed. So the real challenge that I think that we have, and something that coronavirus has certainly spotlighted, is the fact that infection prevention will become critical moving forward. And so we need to think about infection prevention, both from our patient point of view, but also our staff point of view. And really, there are ways that you mitigate against the risk. Of course, there are smoke evacuators. There is legislation around it and the fact that you should be using it. And in fact, I think there is a nice recommendation saying that you should be using it, but I'm not sure that we actually are. So the question for me, and the real big ask from our end, is let's think about this together. Let's think about, how do we protect our staff? How do we protect our patients? And how do we really think about infection prevention from a holistic point of view? Next slide, please. You'll be very pleased to know that that is me done in a nutshell, but thank you very much for your time. I'm really incredibly happy to connect after this, but really, talking about the challenges. So thank you, Jill.
Thank you very much. So we're running a little bit over time. Our schedule's been slightly higgledy-piggledy, tech upset, as you can tell. So we're now going to just revisit one of the areas in the program that was earlier. We're just having some reshuffling in the background just to advertise. We were due to have a talk about the pioneering acute complex biliary pathway by both Stuart Gould and Alberto Isla. Due to a tech hitch, it didn't happen as that, but you'll be pleased to hear there's the opportunity to see Stuart and Alberto, along with Paul Leader and Altaf Awan, talking about this very subject on a webinar sponsored by the ASGBI and Boston Scientific on the 8th of October, Thursday evening webinar. Look out for the details. However, I'm pleased to say that we managed to drag Alberto back, who knows he's on limited time, as our big grand finale speaker. Over to you, Alberto, to tell us about your acute complex biliary pathway.
Thank you very much, Jill. Thank you. And, I'm sorry for all these technical problems, even though it was not our fault. So anyway, I'm an upper GI surgeon. I work at Northwest London Trust, and I support the emergency surgeons and the emergency unit that is led by Stuart Gould. So the biliary emergencies account for 30% of all emergencies. So optimizing its management is always going to be good and saving money and time. So, and the biliary emergencies are mainly represented by cholecystitis without deranged LFTs, obstructive jaundice, and acute pancreatitis. Traditionally, we treated those patients by MRCP them, and if there are stones in the duct, ERCP them at the same admission, or maybe at the second admission, and finally sending them for a laparoscopic cholecystectomy. So the NICE guidelines now acknowledge that the single stage management, which is laparoscopic cholecystectomy plus minus bile duct exploration, is the choice treatment for these patients, provided that there is expertise available. I would say that fits very well in this session now, because in the COVID times, this is especially relevant because avoids second admissions and aerosol producing procedures like the ERCP. So this is the traditional treatment, ERCP followed by laparoscopic cholecystectomy, and this is the single stage management. This is taken from the literature, from the different meta-analysis, and we can see that the single stage management matches very well with the ERCP, but there is an increased incidence of bile leak. In our very own series, with a very high success rate, still we have an undesirable rate of bile leak. This meta-analysis by Ricky found that the combined laparoscopic cholecystectomy plus intraoperative ERCP approach was the safest and most successful, because laparoscopic cholecystectomy plus bile duct exploration that we are promoting and defending appear to have a higher risk of bile leak. We dissected this meta-analysis out, and we found that out of the patients treated with bile duct exploration, we found that only in 36% the transcystic route had been used, having been done most of them through a choledochotomy. So in our very own review of 16 randomized trials in the last 20 years, we found similar data that only 1/3 of the cases are done transcystic. So if the morbidity associated to bile duct exploration comes mainly from the bile leak associated to the closure of the choledochotomy, what can we do to improve this? Maybe increasing the transcystic approach. In our institutional experience published recently in Surgical Endoscopy, nearly 500 cases, we found that indeed the cases done through the transductal route had a higher morbidity, mainly represented by bile leak and pancreatitis. And in the patients treated through the ductal approach, primary closure was associated with high rate of bile leak, closure with an antegrade stent, pancreatitis, and in patients where a tissue was used, they had a long hospital stay. So our mission is to increase the transcystic rate. So how can we do that? We propose 4 steps. One is rectify the angle between the cystic and the CVD. 2, the liberal use of 3mm disposable scopes. 4, use lithotripsy, label technique, and the transinfundibular approach. This is our technique of dissecting the gallbladder first, so the angle between the cystic and the bile duct is rectified and makes the intubation easier. Second, the liberal use of 3mm choledocoscopes, ideally disposable, and we can recommend the newly launched Boston Scientific SPY Discovery that is disposable, 3mm, and enjoys a 4-way steering, which is extremely useful. We were privileged to successfully use this the first time outside of the US. Third, the energy, the label, which is laser-assisted bile duct exploration by laparoscopy, improving surgical outcomes and reducing technical failures. Because indeed, the laser decreases the number of cases that fail because of impacted stones, and as we demonstrated, increases the number of cases than transcystic. That the literature suggests that Even in experienced hands, the proportion of transcystic bile duct explorations is likely to be around 2/3. In our experience, with the use of the energy, we go up to 82%, now 90%. And finally, the use of the transinfundibular choledocoscopy, which is the access to the bile duct through the infundibulum and a cholecystotomy in cases of inflamed hilums, that has proven to be very beneficial. So a cholecystotomy is performed, and the duct is accessed from inside of the gallbladder. So basically, this is our experience since 1998, and we were at a constant rate of transcystic approach in black, about 30-something%, until we introduced these modifications. And this is quite consistent what was published in Ricky's meta-analysis, which is 1/3 of the cases are done through the transcystic route. This is just the summary of the technique. This is a bile duct exploration using the transcystic route in a case with an anatomical variant of extrahepatic bifurcation and a very tiny cystic. So this is our technique of cannulating the cystic, 3 mm scope, and this is indistinguishable from a lab chole. This is a small stone impacted that we laser, and our median hospital stay is of 1 day. So this is what we call the bile duct exploration 2.0, achieving 90% of the cases transcystic with a success rate of 100% and a bile leak under 1%. We label this as bile duct surgery 2.0 as the framework through which, by enhanced techniques and leveraging technology, the transcystic rate in bile duct exploration can be increased to more than 80% with a low incidence of complications, together with promoting its implementation through training and mentoring, with the final aim of improving the outcomes of an increasing number of patients worldwide requiring management of choledocholithiasis. And this has been also very well received by the press. And if anyone wants to see more videos about it, they can see it in my YouTube channel. So thank you for the opportunity of presenting our experience.
Thank you, Alberto. We'll finish with 3 brief questions, one for each speaker because time is pressing on. Alberto, what proportion of surgeons work in the UK that do routine lap cholecystectomy would do laparoscopic common bile duct exploration?
Hopefully, we will be able to give you an answer soon, because the ALICE trial just started and is aimed to looking at exactly this question. There are 2 ALICE, ALICE retrospective and ALICE prospective, and also will give us a picture of, I can tell you, in the US, 93% of CVD stones are treated by ERCP in the conventional way. And moreover, out of the American trainees, the average number of bile duct explorations they do during the training is less than 1.
Laparoscopic or open?
Actually, laparoscopic.
Okay, thanks.
Less than 1.
Thanks, Alberto. Question for Giles. How much was that bone conduction headset? That looked really good. And are there any issues with confidentiality? In other words, can the people pick up on it and realize what you're talking about if you're talking about a patient?
Oh, so yeah, so well, so with the radios, everybody that's on the channel can hear what you're saying, but really, this is for use in theatre. Yeah, that's where it's really in. So you're actually there talking about the patient, equipment, etc. So it's pretty dull to everybody. The bone conduction things vary in price from between about £40 per head up to about £200 per head. And actually, in just trying out the various different types, there seems to be very little in the way that I can appreciate in terms of hearing comfort and things like that. So I'd go cheap as chips. So cheap that actually we're looking for the radios to be universal, used by multiple people, but the headpieces, everybody working in theatre will have their own headpiece, because it's a bit otherwise it gets a bit weird, you know, people putting other people's headphones in. It's a good solution, I think.
Yeah, congratulate on the work you've done on that, Charles. That's excellent. And the final question for Sonia. The administration are very quick at shutting everything down when COVID came along. They've been extremely slow at getting things going again. Having dabbled in the dark arts, why are there so many speed bumps when it comes to getting things going again from the administrators?
So it stopped quite quickly. And I think quite a lot of what we did during COVID, the clinicians said do this and the managers just said yes. And I think they were a bit bamboozled because they didn't have a target to meet and they didn't have a guideline to follow. Some of the restart that's slowed down is because they're not prepared to change their practice. And I think we are prepared to change our practice, and everybody's working differently. We've changed how we provide our clinical sessions. We've changed how we communicate with patients. They still want to work on a 62-day target, RTT. They're looking at things which are by far just defunct now. We should be prioritising patients on their clinical urgency. And the idea of a waiting list and waiting so long and getting your operation done because you've been on the waiting list for so long, it's not the right way. And they just can't quite grasp that. And I don't
still seem to think NHS COVID, don't they?
Yeah, so they're thinking of COVID. I think they're quite reluctant to start. They're worried, and yet they want to start, but they don't quite want to change what they do. We have a lot of middle managers. I'm quite sure that we don't need as many middle managers. I think we need clinicians to get involved. I've done my bit, and I want out. But yeah, the more clinicians are involved, the better by far.
It's been exponential growth of what I call Johnny Clipboards over the last 20 years.
Yeah.
But don't quote me on that.
Yeah.
Okay, that's all the questions. Jill, I'll finish with you, or could you finish off for us, please?
So Professor Sager, that would be Johnny and Jilly Clipboard, don't forget.
Oh, yeah, sorry, yeah.
So I'd like to thank everybody for attending. I'd like to thank firstly Ethicon for sponsoring today. I think it's been a fantastically stimulating day, even in this weird format where you don't get to go to the pub at lunchtime and you can't have a gossip with your friend in the ladies' loo. I'd like to thank all of our speakers for giving us their time, their surgical expertise, their clinical experience, and not least their wit and humour, because I think it's difficult running a thing like this without that. I want to thank especially the ASGBI Secretariat, Vicky, Bav, Carol and Jill, who have been magnificent in the weeks working up to this, and today behind the scenes running around like wild things. Next year's EGS Day, please come. The theme is prioritising emergency surgery and improving outcomes. Want to thank you all for attending. See you all next year, and now we're all off down the virtual pub. Bye-bye.
Thanks, Jill. Bye-bye.
Bye.